you guys ready to get started? So, like Christy mentioned, I actually started my career here at UC Davis as an acute care nurse practitioner back in 1995 and worked here till 2002. And then I just couldn't take driving from the Bay Area to Sacramento every single day back and forth. So I actually moved to UCSF San Francisco General. But it is amazing to see how much this campus has changed. I got so lost, I can't even tell you. It is gorgeous. You guys should all be so proud of what you have here. I do have some disclosures. I'm a consultant for Integra, for diffuse synthes, primarily the Codman neuro aspect of it. And I sit on the planning committee for the AANS Educational Practice Committee and the Scientific Program Committee. Now, I am going to present a case today. It is fictional for everybody, okay? So just know that going into it. My goals today are to help you identify some physiological factors which actually contribute to secondary brain injury. You heard about that yesterday. You're going to hear a lot about it today. We're going to discuss intracranial hypertension and the three-tiered approach to ICP management. And I'm hoping to give you some nursing strategies that you can actually utilize at the bedside. Now, I don't think I'm going to be giving you a whole lot of new information, although I hope some of it's new. My whole goal today is to change how you think, to really change how you approach these patients, and to really get you thinking about individualized patient care. Because not every TBI is the same, okay? So we should be tailoring our care based upon what's going on with them at that physiological moment, because it's going to change and evolve. So TBI as a disease is non-discriminatory. Every 15 seconds, someone in the US suffers a traumatic brain injury. Every 5 minutes, someone is forever disabled. Those are huge statistics. If you look at HIV and cancer combined, TBI accounts actually for more cases, okay? But yet it gets the least amount of funding and the least amount of attention, although concussion has brought it to light recently. But there's a lot more past concussion. These severe TBI patients, if they get the appropriate care and intervention in a timely manner, have incredible outcomes. So never forget that, okay? So the most important thing you should know is that not all TBI actually occurs at the moment of impact. It actually evolves over ensuing hours and days. After the initial injury, the brain undergoes chaos within the cranial vault, and it becomes extremely vulnerable to things such as hypoxia, hypotension, hyperhypocapnia, increased intracranial pressure. All these things lead to a phenomenon that we have been referring to yesterday and again today as secondary brain injury. And you guys really are the key for intervening and preventing that from occurring. So, as I mentioned, this is a fictional case, and for the rest of this talk, we're actually going to use a somewhat loose case-based approach, and I'm going to ask you to participate with some questions as we go on, because like I said, I want to wake you up since I'm first. So, we have a 28-year-old female, status post-MVA, a strained driver. There was no airbag deployment, positive LOC, positive post-traumatic amnesia, no witness seizure activity, GCS in the field was 9, E2, V3, M4. Her ETA to the hospital is 10 minutes. We have very short transit times in San Francisco. So for the rest of this study, we're going to call her trauma Xerox, okay? By the time trauma Xerox reaches your hospital, our GCS drops to 6. Now, red flags should be going off in your head. And the reason is because anybody who has a GCS less than 8, you shouldn't wait, you should intubate, okay? This should be your motto. And the reason is because hypoxia is the most common and lethal of all secondary brain injuries. In fact, literature has shown us that greater than 70% of all TBI patients will experience a hypoxic insult within the first few hours of care. Single episode of hypoxia leads to a 2-fold increase in mortality in these patients. Hypoxia is defined as a PaO2 of less than 60 or saturation of less than 90. Okay, here's where the questions come in. How many have taken TNCC? Few of you out there. So in TNCC, they teach you ABCD, right? So that's how we're going to approach trauma Xerox. So we covered A, airway. Let's talk about breathing. So knowing she likely has a TBI, should we be hyperventilating her? Well, here's some more facts. We know that CBF decreases TBI, and it's most pronounced within the first few hours of injury. We also know that hyperventilation, Linda alluded to this yesterday, and we're going to talk more about this, results in a decrease in CO2, which causes vasoconstriction. We know that vasoconstriction decreases the cerebral blood flow. So the take-home message is hyperventilation results in a decrease in cerebral blood flow and contributes to additional cerebral ischemia. But where does this come from? Well, here's that blue book that Linda's doc keeps on the shelf. I'm going to encourage you to look at this blue book. These are the guidelines for the management of severe traumatic brain injury. They were first established in 1995. They underwent their latest revision in 2007, and they're undergoing their 4th revision right now. We're hoping the new guidelines are going to come out in fall or early spring. They were slotted to come out last spring. However, the reviewers weren't really on board with some of the recommendations they made, so they had to go back to the drawing board and look at the data again. These are evidence-based guidelines, and they really should be guiding your practice, okay? And the guidelines do not recommend the use of prophylactic hyperventilation. In fact, the only time you should even consider hyperventilation is as a temporizing measure for the reduction of elevated ICP. However, once again, they warn that it should be avoided during the first 24 hours of injury when your blood flow is already reduced. Okay, we got A, we got B. Let's talk about C, circulation. We know that withholding fluids is potentially harmful, okay? So aggressive fluid resuscitation is imperative during the initial phases of care. We also know that hypovolemia exacerbates secondary brain injury by causing hypovolemia. Now notice I highlighted initial. And the reason is because that does not necessarily hold true later on, and we're going to talk about this, where aggressive fluid resuscitation, if not controlled, can actually cause increased ICP. Once again, the literature shows us that 35% of all TBI patients will experience a hypotensive episode during their initial phases of care. Single episode of hypotension leads to a 2-fold increase in mortality. But look at this. 8-fold increase in mortality with 3 episodes. These are single spot episodes of hypotension. Hypotension is defined as a systolic blood pressure less than 90. What fluid should we be resuscitating with? Okay, well, here's some rules of physiology before I get you to vote on that question. We know that the brain is surrounded by a blood-brain barrier. It separates it from the vascular space, right? In general, the blood-brain barrier only allows water to pass through. We know that the sodium concentration in the plasma is usually greater than the sodium concentration in the brain. And we know that water loves to influx areas of high sodium concentration. So, how many of you, show of hands, want to resuscitate with normal saline? How many want to use D5/2? How many don't know and don't care, and I'm still asleep and need more coffee pumped in? Because I'm not seeing a lot of hands going up here. Well, I'm here to tell you, you should never be considering using D5/2. And the reason is because what happens with this dextrose, okay, is that it gets metabolized out. And the fluid that's left is a very dilute saline solution. And guess where that dilute saline solution goes? It goes into the plasma, okay? And it dilutes out the sodium concentration. And look at this. Now your sodium concentration in the brain is so much higher than that sodium concentration in the plasma. And what did I tell you? Water loves to influx those areas of sodium high concentrations. So it's going to move from the plasma into the brain, and you're going to get cerebral edema, okay? So your fluid of choice should be something that has an equivalent plasma level of sodium, which is normal saline. Now the only exception to this is episodes of hypovolemia. With hypovolemia, you should be given blood because what you want to do is increase that oxygen carrying capacity to the brain. So you need to be thinking about these things. All right, back to trauma Xerox. After stabilization in the ER, we're going to take her to the head CT. Okay? Her head CT, although I didn't put it up here, shows a left subdural, a left frontal contusion, and a left temporal contusion. Now you should be extremely worried when you see these contusions. A lot of times on initial head CT, you really can't even see them. You can kind of see some glimpses on the outside, but at 6 hours, they're going to blossom. And the reason contusions are so threatening is because they continue to evolve and get worse over the first 48 hours of injury. They don't reach their peak until 48 hours, and that's when these patients start getting in trouble. Okay, so she gets her resuscitation, she gets her CT. We're going to go to ICU. Okay? Now, this transport time is extremely critical. And the reason is because 30% of all secondary brain injuries occur during transport, from things such as hypoxia, hypovolemia, and hyperventilation. Because if you notice, she's bagging this patient here. What happens when you're bagging? Well, you're bagging, but really you're talking to your friend about what you did last night. And the next time you look down, your bagging rate has almost tripled. And now you're causing unintentional hyperventilation in this patient and causing them to have a secondary brain injury. So you really need to be thinking about these things. And once again, this is a critical time for causing secondary brain injury. So we get her to the ICU. Here's your first set of vital signs. Okay? We got a heart rate of 50, blood pressure 210/105, respiratory rate of 44. Now, you're also going to get an exam on her, and she now has a fixed and dilated pupil. How many are concerned? Okay, every hand should be up. And the reason is because hypertension, bradycardia, and tachypnea is Cushing's. Okay, the Cushing's is the body's attempt to bring down that ICP. Okay, it is an ominous sign. This is telling you that the brain is herniating. You got to intervene. You got to do something. So we're going to intervene with Xerox. We're going to give her mannitol based upon the guidelines. Now, the guidelines restrict mannitol use prior to ICP monitoring to patients with signs of transintracranial herniation or a neurological decline not attributable to an extracranial cause. She gets her mannitol, and we're going to talk about mannitol more later, and she has a return of her pupil reflexes. All right, at this point, who wants to put a monitor in? Anybody? Anybody? Okay. Linda alluded to this yesterday. There is some loose controversy out there about monitoring these patients. How many of you have seen this study? Anybody? It was put out in, I see one back there from Integra. He should know this study. It was first put out in 2012 in the New England Journal of Medicine. Okay? It was a randomized controlled trial conducted in general ICUs in Bolivia and Ecuador. There were 324 severe TBI patients over the age of 13 in this study. Now, look at this. This says it's a trial of intracranial pressure monitoring. What does that lead you to believe? In reality, what it was a trial comparing two management strategies in which treatment was actually triggered by either ICP measurements or clinical exam and CT findings. Okay? What was interesting in this trial was that standard treatment protocols were only established for patients without monitoring. Now, despite this, the outcomes were pretty similar. There was a slight trend toward lower mortality and more efficient care in the ICP monitoring group. But I'm going to draw you back up here. It says it's a trial of ICP monitoring. And so what this did was it raised a lot of public misinterpretation of what this study was about. They assumed that the clinical implications were, we don't monitor. It really set the neurotrauma community in an uproar, okay? Some of the other misinterpretations include that the best trip trial was irrelevant to treatment in high-income countries. Clinicians started questioning the guidelines and the indication for monitoring, and it actually put a moratorium on ICP monitoring in some institutions. And there was some concern about that there were limitations on insurance reimbursement if you did put ICP monitoring in. And so there was a lot of collateral damage just from this single study alone because people misinterpreted it. So the neurotrauma community, all the clinical leaders got together from the AANS and the CNS, and they developed some consensus statements to help interpret this study. The statements they came out with were the best trip trial compared, once again, two management strategies. It was never intended to be a trial of ICP monitoring or the efficacy of ICP monitoring. It also should be considered a research trial. Okay, it suggests that further investigation is needed for the selection of patients and the treatment thresholds for these patients. They stated that the role of ICP monitoring in directing the treatment of established intracranial hypertension was never a focus of the best trip trial. And lastly, and most importantly, for those that were currently monitoring ICP, the best trip trial should not change their practice. And unfortunately, it did. So it took a lot for us to get this message out there. And hopefully, we're now starting to change that thought process. So what do the guidelines say? Well, the guidelines say that ICP monitoring should occur in all patients with a severe TBI defined as a GCS of 3 to 8 after resuscitation and an abnormal CT. Or this group, okay, a patient with a severe TBI and a normal CT if you have 2 or more of the following on presentation. Age greater than 40, unilateral or bilateral motor posturing, or systolic blood pressure less than 90. Okay? Let's go back to trauma Xerox. Clearly she meets some of these criteria, correct? Who wants to put a monitor in? Okay, everybody should be raising their hand at this point. Okay, let's talk about what kind of monitor. Who wants to put an intraparenchymal monitor in? Anybody want to put an EVD in? Okay, good. Okay, the EVD is considered to be the gold standard of care for TBI, okay? The EVD allows for detection of increased mass effect, calculation of a CPP, and it gives you a widely acceptable endpoint for therapeutic intervention. We put our ICP monitoring in, and here's your opening pressure, 23 to 26. All right, are we concerned? Yes. Okay, but before we start talking about are we going to intervene or not, let's talk about what makes up ICP. Okay, because I think this is an important concept that everybody should understand. So ICP is the combined pressure contained within the skull. Within the skull, you have the brain tissue, which makes up 80%, the blood flow, both arterial and venous, which makes up 10, and the CSF, which makes up 10. In order to maintain a dynamic equilibrium between these 3 components, one enlargement of one needs to be offset by another, because you want that constant dynamic equilibrium occurring, okay? Now the formula for ICP, if you look at a straight formula, is CSF production times resistance to outflow plus the sagittal sinus pressure. The sagittal sinus pressure actually makes up 60 to 70% of your ICP. So does anybody know what normal sagittal sinus pressure is? Okay, I didn't either. What's normal CVP? 5 to 7? Well, your CVP is equivalent to your sagittal sinus pressure. So what kind of things do we do every single day in the ICUs and the floor that increase your CVP? That too. Suctioning does that too. But what about this? Remember I told you initially that aggressive fluid resuscitation is great because we want to avoid hypovolemia? But continued aggressive fluid resuscitation can increase your CVP and thus cause an increase in ICP, okay? This is where you guys are the gatekeepers, okay? You need to be thinking about these things because, once again, sagittal sinus pressure makes up 60-70% of your ICP. And your sagittal sinus pressure is equivalent to your CVP, okay? Back to trauma Xerox, told you ICP of 23 to 26. Concerning, right? So what do the guidelines say? When should we be treating these patients? Well, they recommend using a combination of ICP values and clinical and brain CT findings to determine the need for treatment. But in general, they've set a threshold about 20. Now, this is going to change in the new guidelines, but for right now, it is set at 20. Because we know that beyond age and neurological examination, the amount of time that that ICP is greater than 20 is most predictive of outcome. Okay? So clearly, she meets these criteria, so we need to treat. But how do we want to treat? Okay? I love guidelines, so we're going to go back to these guidelines, okay? And we're going to talk about a 3-tiered approach to ICP management. And the guidelines and the tiered approach I'm going to present to you are based upon the American College of Surgeons TQIP guidelines, which are from the severe TBI guidelines. Does anybody know about ACS TQIP? I see one hand over there. So it is primarily for level 1, level 2 trauma institutions. It's a way to nationally compare your outcomes against other like institutions. It's a huge database, okay, which allows for benchmarking. It is an incredible opportunity for trauma centers to really look at the outcomes in care. Because as you know, with all the healthcare changes, what are they looking at? Outcomes in care. Okay, this is our way to be able to benchmark, correct? All right, so let's talk about the tiers. We're going to go through each of these. Tier 1, it's really about bringing it back to the basics, okay? It's what you guys do every single day. It's head of bed elevation. sedation and analgesic, EVDs, and once again, going back to that neurological examination and repeating a head CT. Because if a patient has a mass lesion, you need to get them to the OR, right? We're going to break these down and talk about how they affect ICP. So as I mentioned, the first thing in Tier 1 is head-to-bed elevation. But it's not just about head-to-bed elevation. There are other positioning things you really need to consider. For example, if your neck is flexed and rotated, you're decreasing your jugular venous outflow, and guess what? Increasing your ICP, okay? Head-to-bed elevation greater than 30 degrees is great, and the way it works is by decreasing your CPP, decreasing your mean arterial pressure, which then decreases your ICP. It is a great maneuver. But once again, let's see a show of hands. How many put the head of bed up 30 degrees, and because our ICU beds are slick, what happens? They slide down. So what do? We do this, okay? Because we wedge them in. We don't want them to slide down. You gotta have your sheets ready for the next shift, correct? I mean, come on. You don't want to get in trouble. Hip flexion, greater than 90 degrees, increases your vena cava pressure and will increase your ICP. So think about that next time you jack them up into this position, okay? Turning affects all your vasculature. If you have adverse effects, stop and reassess. Maybe your patient needs more sedation, okay? So that's going to transition us into the second part of Tier 2, which is sedation, okay? If your ICP becomes elevated, you may want to consider your patient's level of sedation and analgesic. Ask for a drip. A drip is going to provide you with a more consistent therapeutic level than you will ever be able to achieve with PRN dosing, okay? I've listed fentanyl, Dilaudid, propofol, Dex, and Versed here, okay? My institution, we usually start with a fentanyl drip. We start with propofol, but then we might move to Versed if they're resistant to propofol. Okay? But I'm going to caution you, because guess what happens when you give these drugs? Hypotension and hypoxia. Single episode of hypoxia, single episode of hypotension, twofold increase in mortality. 3 episodes of hypotension, 8-fold increase in mortality. So let's go back to our resus. She comes in hypovolemic. 1, you intubate her and you start propofol in the ED, and you're not really good about putting them on a monitor, and so the propofol is running and you don't know that she might be hypotensive. 2, and then you bring her to the unit and you may load her with Dilantin. What does Dilantin do? Or phosphatidone even does this. Drops the pressure. 3. Okay, think about these things when you're providing this care. It happens and you don't even realize it's happening. Once again, you guys are the gatekeepers. Okay? Although these things aren't listed in Tier 1, I think they deserve attention, okay? Because these things affect ICP. If your C-collar is too tight, if you have circumferential ET tube taping, decreases your venous return, increases your ICP. Constipation and abdominal distension increases your intra-abdominal pressure, thus increasing your ICP. Make sure they're on a routine bowel regimen and they're having routine bowel movements. And if you don't believe me, next time you have a patient in the ICU hooked up to a monitor, go press on their belly and see what happens to your waveform. You will see a sudden spike in your waveform. And a lot of times we actually do that to make sure that our waveform is truly accurate and that our monitor is working. Because it will suddenly spike up, and then when you release the pressure, it'll come down. Fluid management, okay? You admit the patient to the ICU, fluids running at 100 cc's an hour. That's fine. Okay, if you're following the guidelines say that you should start nutrition within 24 to 48 hours, okay? Fine again. Tube feeds are going 20 cc's an hour. The order says 20 cc's an hour, increased by 10 cc's an hour every 8 hours to meet your goal of 60 to 80 cc's. Okay, you reached your goal. Guess what hasn't happened? You haven't decreased your IV fluid. So think about what's happening here. You have a fluid rate, total fluid rate, of 180 cc's, and that's not including your propofol, your fentanyl, and God forbid any antibiotics or anything else that's running. So you need to think about these things, because this is where, once again, you're getting in trouble. You know, CVP, sagittal sinus pressure, 60 to 70% of your ICP, okay? So the third option in Tier 1 is an EVD, okay? Clearly she's met this criteria. We already have a value, we know. How do you want to manage it? Who wants to leave their EVD open and continuously drain it? Okay. How about close to monitor draining intermittently for an ICP threshold? Anybody? Anybody don't know? And that's okay. Both of these are actually acceptable methods for reduction of ICP. So let's talk about the advantages of both of them. Okay? Continuous monitoring with intermittent drainage. The advantages are it provides you with an online real-time measurement of ICP. It gives you a continuous waveform to analyze for brain compliance. So here's a normal waveform, okay? P1 is the first spike. P1 represents arterial pulsation. P2 is the next hump, right here. P2 represents brain compliance. So what happens in TBI is that the brain loses compliance, and the waveform that you're going to see is a P2 that's now higher than a P1. This is classic for someone who is in trouble, okay? The other thing you need to know, and I didn't put this waveform up here, is once you do a decompressive hemicraniectomy, what happens to your waveform? It kind of somewhat flattens out. You don't have this incredible distinction that you have here. And why? Because you've altered compliance. You've changed the box, right? When you change something in the box, even the skull, you've changed your compliance. And so your waveform becomes muted, okay? The other thing that this way of managing your EV does is it gives you an option for CPP monitoring, and it allows you to look for autoregulation and potential loss of autoregulation. And we're going to talk about that in detail in a little bit. Now, what are the advantages of continuous? Now, traditionally, the teaching has supported intermittent drainage. However, there are some studies out there that now support continuous drainage. The advantages that they found are things such as continuous drainage allows for more CSF removal than intermittent. Continuous drainage can lower your mean ICP values. It's been shown to have a reduction in CSF markers following TBI and a reduction in overall ICP burden. Okay, so that sounds pretty good, right? The one thing that these studies have in common is that they say if you are going to leave it open and continuously drain, you need to put an intraparenchymal device in so that you have ongoing real-time ICP monitoring. Now, I know Matt back there is going to love us because now we're putting in an intraparenchymal device and an EVD. But it's important because you need to have that continuous ICP monitoring, right? And it also allows you to look at the congruency between the two systems to see if your values are truly accurate, correct? All right, back to trauma Xerox, okay? So we've kind of exhausted tier 1. Let's move to tier 2. In tier 2, if she has a parenchymal monitor, you're going to make her have an EVD. You're going to start thinking about hyperosmolar therapy here. And you're going to think about cerebral autoregulation. Now, in the absence of intact autoregulation, this patient might do better with lower CPP goals, and we're going to go into this. This is also the point where you might want to consider those fancy monitors that Linda told you about yesterday, because these monitors will help you determine what your optimal CPP is. Okay? So let's break these down. Hyperosmolar therapy. Okay, there's a lot of studies out there comparing the use of mannitol versus hypertonic saline. The problem with these studies are there's no single identified dose. You have mannitol at 25, 50, 100 and escalating doses compared to hypertonic saline at 3%, 7%, 23.4%. So how do you do an accurate comparison of efficacy if you don't know what dose to give? The other thing you need to remember is that TBI care is really an infant right now. Okay? We really only have 3 or 4 drugs at our availability to help or do anything. And we don't even know what the therapeutic dose threshold for these really truly are. So when you read these studies, you need to be thinking about those things and think about how they're comparing themselves to each other. Okay? What we do know is that mannitol works as an osmotic diuretic. It creates an osmotic gradient, forcing water out of the neurons into the plasma. So how does it do this? It does this by acting as a renal vasodilator, preventing water absorption. And within the renal tubules, it holds on to water and sodium and excretes them through the urine. Okay? Its effect takes about 15 to 30 minutes. Now, the correct way to administer mannitol is get it in as fast as possible. If you're going to use a pump, it's 99999. If you're not using a pump, you need to get up there and squeeze that bag in because you want to create that gradient, okay? A slow drip is never going to get your gradient, okay? Get it in as soon as possible. Now, the other thing you need to know is that continuous infusions can actually exacerbate edema and increase your ICP. So how does it do this? Well, it does this because mannitol actually moves into the interstitial spaces of the brain, okay? And it does this by breaking down the blood-brain barrier. In fact, on post-mortem, they have found mannitol crystals in injured brain, okay? So think about that whenever you're given excessive doses of mannitol. It is actually depositing in the brain. I'm not saying don't use mannitol, it's our first line. But think about how much mannitol. And if you're not getting your effect with mannitol, maybe you need to go to hypertonic saline. Okay, individualized patient care, that's what it's about. Okay, the threshold for mannitol is usually 300, 310, 320. Never above 320 because you start to get tubular necrosis. Okay? What about hypertonic saline? Well, it works its magic by, once again, creating an osmotic gradient. Okay, when you give hypertonic saline via IV, it changes the concentration in the plasma, correct? So now you have a plasma concentration of sodium that's higher than the brain. What happens? Water goes from the brain to the plasma, okay? Hypertonic saline is great. We actually use 23.4 cc bullets. It's pushed by either us or the attendings or the chief resident. It is a slow push because it has cardiac effects. It is over 10 to 15 minute kind of a push. It's a slow push. But it's incredible. It's an incredible drug to use, and you can see the effects almost immediately in a patient. So if you have a patient who's not necessarily responding to mannitol, flip to hypertonic, okay? Because the brain equilibrates. It's a smart organ, man. It's a lot smarter than the lub-dub cardiac thing. You know, that's all I'm saying. So, the guidelines recommend the use of mannitol in intermittent bolusing. The bolus dose, 0.25 to 1 grams per kilogram per body. Notice that I gave you a range here. And the reason is we don't know, right? But they do know you gotta be cautious if the patient's hypovolemic because it causes hypotension, okay? Your threshold, 320, and you should be monitoring your serum osms and sodiums every 6 hours. Hypertonic saline, intermittent doses again here. Notice that there's nothing about continuous on here. And that's because prophylactic nothing is nothing, okay? You should never be doing anything prophylactically, okay? That's a little different than in stroke, although I have my opinions on that, where they do a lot of continuous infusions. In TBI, you should never be doing continuous infusions of anything. You can give 3, 7, or 23.4%. Like I said, we give 23.4, and your threshold, once again, is 160, okay? So the next part of Tier 2 is autoregulation. Okay, Linda hit on this a little bit yesterday. Cerebral autoregulation is a dynamic state of vasoconstriction and vasodilation to maintain a consistent flow in the brain despite changes in systemic arterial pressure. Linda mentioned this yesterday. It likes a map between about 50 and 150. However, this is really an idealized curve. Think about your hypertensive patient. They're usually used to seeing maps in the higher end, and if you drive their pressures down too much, what happens? They start to show symptoms. Versus your athlete, who's down here, okay, they do just fine down here, okay? So how does it work? Simple. Blood pressure goes up, vascular system responds by vasoconstricting, maintaining a constant flow. Normally, the brain likes about 55 cc's of blood per 100 gram of brain tissue, okay? Blood pressure drops, vascular system responds by vasodilating, once again maintaining that constant flow. Problem with TBI is you get impaired autoregulation, and the brain becomes pressure passive, okay? And what this means is as your mean arterial pressure goes up, the vascular system is impaired and can't respond and vasoconstrict, so you get a corresponding rise in your CPP and your ICP. Make sense? Blood pressure drops, you'll see a drop in your CPP and a drop in your ICP. So how do you know if your patient is pressure passive? Any ideas? Well, there's two ways, and you guys are, once again, the key to this. Following hemodynamic trends. If you notice, because you're sitting at that bedside for 12 hours, if you notice a rise in your MAP and a subsequent rise in your ICP and there's a trend there, chances are your patient is pressure passive, okay? Now, the other way you can tell is by doing autoregulatory challenges. And we routinely do these. We challenge against pressors and we challenge against CO2. So what I mean by this is if you raise your mean arterial pressure or lower your mean arterial pressure by 10 and you get a corresponding change in ICP, chances are your patient's pressure passive, okay? And if your patient is pressure passive, they may do better with lower CPP goals in the range of 50 to 60, right? Because think about it, if you lower your CPP, they're pressure passive, you're bringing down your ICP. The problem is these patients pop in and out of autoregulation multiple times throughout their hospital course. So it's something that needs to be routinely assessed and watched. Follow those hemodynamic trends. Now, you never want to set a CPP goal of less than 50. Also in Tier 2, okay, we have PaCO2 recommendations of 30 to 35. However, you should avoid it at all if there's any chance that the brain's hypoxic, okay? This point also, you can put in those fancy devices to help you determine that correct CaO2 level, okay? Back to that neurological examination, you always got to go back to this neurological examination and consider a head CT to make sure there's no mass lesion. And at this point, you can consider neuromuscular paralysis. Now, if you are going to paralyze someone, you should probably give a test dose to see if there's a positive response. If there's no positive response, don't even bother with this. It's not going to work, okay? Okay, if you are going to start an infusion, you need to maintain at least 2 twitches, and you always, always, always have to sedate these patients. The worst thing is to have a patient tell you, I remember everything. And that happens sometimes in the OR if you don't have enough sedation, okay? But we're going to focus on this right now. Let's talk about the CO2 and pH regulation because it's an incredibly powerful system. And it actually stays in place until brain death actually occurs. It is the most powerful thing, okay? So the brain doesn't like to be starved of nutrients or oxygen, okay? It likes that constant flow. It's hungry, okay? It uses 25% of all stores of everything, okay? It's a very greedy organ. So if your CO2 goes up, vascular system responds by vasodilating because once again, it likes that constant flow, okay? This effect occurs after about 2 minutes. For every millimeter change in CO2, you get about a 2 to 4% change in cerebral blood flow. But what happens when you hyperventilate? I already told you, unintentional hyperventilation occurs a lot, okay? You're talking about Friday night, and the next thing you know, you're hyperventilating someone. When you hyperventilate someone, you blow off your CO2. As you blow off your CO2, you get a rise in your pH. Vascular system initially responds with vasoconstriction. However, after 12 minutes, it starts to sense, oh my God, I'm dying here. And the vascular system responds by vasodilating, okay? It's an incredibly powerful machine. I cannot keep saying that enough, okay? However, hyperventilation is good, but only as a temporizing measure. And the reason I say this is because after about 6 hours, you get chronic adaptation. And no matter what you do, blood flow is going to return to pre-alteration levels. Smart organ. But you got to be cautious because vasoconstriction and vasodilation can lead to secondary brain injury, okay? Nothing worked in Tier 1, nothing worked Tier 2. Let's talk about Tier 3, okay? In Tier 3, you have a decompressive hemicraniectomy. There's that paralysis again. At this point, you're starting to look for salvage stuff, so think about barbiturate or propofol, anesthesia, dose comas, okay? However, you need to be cautious because of hypotension, right? You also need to think about propofol infusion syndrome. Propofol infusion system, the risk factors for that are TBI patients, young males, and infusions of greater than 83 mics per kilogram per minute for more than 48 hours, okay? If you are going to put someone in a coma, please do an EEG to make sure you're achieving burst suppression. Otherwise, why do it? So let's talk about decompression, okay? There's lots of controversy about decompression out there. Linda presented the Decretile yesterday, okay? It is not a benign procedure. It does have some risk factors, depending on how you define risk factors and complications. And there's no standard way for defining what is a complication, okay, like many things in medicine. If you are going to do it, you need to go big or go home. And what I mean by that is you need to take off the whole half side of the skull, okay? You need to do a huge dural opening, and you need to only close the skin, okay? And the reason is because think about what happens as the brain swells, okay? If you have an intact skull, where does it go? It's looking for escape. It goes down, okay? You do a decompressive hemicraniectomy like a cookie cutter, like you do with tumors or vascular cases. Where's the brain going to go? It's going to go there. And what's going to happen is you're going to pick off your blood supply, and you're going to get infarctions, okay? Now you've not only had worsening secondary injury, but now you got a stroke on top of that, okay? So go big or go home, okay? The last thing I want to say, well, actually two more things in this tier, is that if you're going to paralyze someone or put them in a coma, you need to always keep in mind the risks associated with that. VAP, ARDS, ileus, DVTs, and these people need aggressive pulmonary care because they will get a pneumonia. I can guarantee it. They will likely get ARDS, and this is where whoever asked the proning thing, the proning starts. The last thing is hypothermia. I'm not going to go into hypothermia, but you need to know it is considered a rescue or salvage therapy only. Okay? So, I've introduced these tiered therapies. But really the take-home message for all you guys is you need to constantly stop and reassess what's going on with your patients. Think about it. Is this a brain or tissue problem? Is it a CSF flow problem? Or is it a blood flow problem? Okay? If it's a brain or tissue problem from a mass effect, it doesn't matter how much CSF you take off. What's going to fix this patient is a decompressive hemicraniectomy and evacuation, right? If it's a CSF flow problem, you better change the intraparenchymal monitor to an EVD. And if it's a blood flow problem due to loss of autoregulation, lower your CPPs. This is what I'm talking about by targeted therapy. This is where you guys are key to really having an influence on your patient's outcome, okay? So because I don't want to leave trauma Xerox hanging out there, by hospital day 2, she reached her maximum medical management. She was still experiencing malignant hypertension. She went to the OR. Here's her decompressive hemicraniectomy. This is what I mean about going big, going home. You look at this as compared to the other one. Size of this, 17 by 13 centimeters, okay? So don't forget, time is brain, and not all brain injury occurs at the moment of impact. The brain is vulnerable to all these things, okay? And these lead to your secondary brain injury. Now, I want everybody to look around, okay? Because you guys really are the key to preventing secondary brain injury. Your care, your bedside care has the most important effect on patient recovery and outcome. And I cannot thank you enough for the care and compassion that you actually have. You're invaluable. You really are invaluable to the outcome of these patients. So I started out by telling you that TBI is non-discriminatory. And in my 45 minutes, 180 people suffered a traumatic brain injury. Pretty outstanding, isn't it?